Good morning, everyone. My name is Claudia Fox. I'm from the University of Minnesota, and today I'm going to be discussing the medical assessment and management of obesity in people with cystic fibrosis. I do have a few disclosures. I receive research support from Novo Nordisk and Rhythm Pharmaceuticals for participating in some of their research projects. So to start off, when I was first asked to do this presentation, I thought, wow, do people with cystic fibrosis really have obesity? Is that an issue? And the more I did research, in fact, I found that it is actually becoming more of a problem. In fact, some studies indicate that almost a quarter of patients with cystic fibrosis have a BMI in the overweight range, which is defined as a BMI between 25 and 30. And up to 10 or even 11% of patients with cystic fibrosis will have a BMI in the obesity range, which is defined as a BMI greater than 30. So why should we care? After all, we know that BMI is positively correlated with lung function. But there are some studies that indicate that in adults, there's no additional benefit on FEV1 when the BMI is greater than 23. And remember, overweight starts at a BMI of 25. And for children, lower BMI is not necessarily associated with the worse lung function unless the BMI is very low, that is below the 10th percentile. Further, obesity in individuals with cystic fibrosis may contribute to worsening cardiometabolic health. Specifically, there is an increased risk for hypertension, dyslipidemia, diabetes, sleep apnea, and there are studies that also suggest that obesity may contribute to worse lung transplant survival rates. So what causes obesity? We think about generally eating too much junk food or sweets, not getting enough physical activity, but actually this is all wrong. Those are perhaps a symptom of obesity, eating poor food and not moving enough. Rather, obesity is a sign, just like fever is a sign of an underlying disorder, perhaps an infection that requires further investigation. Obesity is also only a sign. It's a sign of a chronic disorder of energy regulation. And this energy regulatory process is termed energy homeostasis. And so this is the process that tells us to eat when we're hungry, but then also to stop eating when we feel full. And this process is controlled by multiple peripheral signals. So we get signals from our intestines, our stomach, our pancreas, our muscles, and our adipose tissue, our fat cells. All of these signals integrate at the level of our hypothalamus to tell us if we should be eating or not eating. And it's disruptions in this energy homeostatic processes that contribute to obesity. There are multiple disruptors of this process. Obesity is a super complex condition, but we can sort of simplify these contributors to obesity as biological factors, some psychological factors, and social factors. And of these, the most prevalent or the most salient, the biggest disruptors of energy homeostasis are biological in nature. So we'll review these very quickly. Of the biological factors, genetics is the most potent. 40 to 70% of the variability in our BMI is related to genetics. So obesity is an inherited disorder. It is genetically based. There are also some prenatal disruptors of energy homeostasis. These may include excess weight gain in the mother during gestation. It may include gestational diabetes. There are single gene mutations and syndromes which can contribute to obesity via disruption of this homeostatic process. There are endocrine disorders, though generally quite rare causes of obesity. Additionally, there are many obesogenic medications. Perhaps relevant to this conference is the CFTR modulators. And indeed, these may unmask obesity in the following ways. And Dr. Stallings is probably going to be talking about this in quite a bit more detail. But to summarize, they can decrease GI symptoms, which may allow for more food consumption. They also decrease resting energy expenditure, such that a person may need relatively fewer calories to maintain their weight status. And further, these medications may decrease gut inflammation and improve fat absorption, in essence, allowing the body to process or absorb more calories, if you will. And there's yet another biological factor that may be contributing to obesity in this population, and this is something that I consider sort of iatrogenic. In particular, we know that nutrition guidelines for cystic fibrosis recommend that patients ingest a calorie intake of 120 to 150% of the recommended daily allowance. However, there are at least a few studies that show that in children with CF during times of health, that their resting energy expenditure is only about 110, 105, 110% of predicted, so much lower than what is recommended by nutrition guidelines. And further, another studies show that there's no difference in resting energy expenditure between children with CF and those with normal controls, but those with CF were consuming more food. Among the non-homeostatic contributors to obesity, so these are mechanisms that lead to obesity because of eating in the absence of hunger. These include depression, anxiety, ADHD, binge eating, eating when bored. And of course, the social or environmental factors play a role for people with CF as well, naturally. One that I do want to highlight is this notion called perceived vulnerability. And this is the idea that parents of children who have serious, life-threatening, sometimes chronic illnesses, such as CF, may view their children as particularly sensitive or vulnerable to insult. And so these children are sort of overprotected, and perhaps coddled to the point that may lead to some harm to the child. And so it may be that kids with CF are encouraged to eat more, even when they don't really perhaps need it. They are overly protected from participating in physical activity when perhaps that may not be particularly beneficial. So regarding the management of obesity, I have to start off by saying that there are no guidelines with respect to managing obesity in patients with cystic fibrosis in particular. So I'm extrapolating a little bit. Having said that, it seems that it's probably most appropriate to start by targeting those at highest risk. So that may include patients with less severe forms of CF disease, and also perhaps those who have a family history of obesity. It's important to screen for weight-related health problems that can exacerbate weight gain, so that including diabetes, for example. Lifestyle intervention is at the cornerstone of obesity treatment. And with respect to diet, it may be prudent to measure the resting energy expenditure of your particular patients to assess their specific calorie needs. It might be that they don't need the recommended 120 to 150% of the RDA. We should be aiming for 500 calorie a day deficit, and the optimal dietary composition in terms of relative amounts of fat versus carbohydrate is really unknown for patients with CF. Similarly, particular exercise guidelines for patients with CF are not clear. For the general population, we are recommending 60 minutes of moderate to vigorous physical activity. There may be a role for weight training, in particular for patients with CF, because the weight training can increase lean body mass, which tends to be lower in patients with CF, and that lean body mass really increases a patient's resting energy expenditure. Medications are an integral part of therapy for many individuals who have obesity. For adults, indications for weight loss medications include a BMI greater than 27 in the presence of weight-related comorbidities or greater than 30. And for children, it's BMI greater than the 95th percentile with weight-related comorbidities or greater than 1.2 times the 95th percentile, which is characterized as severe obesity. And here's a list of the medications which are currently FDA approved to treat obesity. Orlistat is a lipase inhibitor, so it's going to block the absorption of fat. I'm not sure that this would necessarily be an appropriate one for patients with CF, maybe some patients who don't have very much GI involvement. Liraglutide is a GLP-1 receptor agonist that's also used to treat type 2 diabetes, so this may have some potential benefit. Phentermine is a stimulant medication, and phentermine plus topiramate is another one, and yet finally naltrexone plus bupropion. The ones that are starter, those that are FDA approved for the pediatric population, this is going to be FDA approved for pediatric population this year. That's why the parentheses is there. Regarding surgery, some individuals do benefit also from bariatric surgery. The most commonly performed surgery at this time is called the vertical sleeve gastrectomy, in which the fundus of the stomach is removed and the remainder of the stomach resembles a long tube, such as that looks like a sleeve. Indications for bariatric surgery include having a BMI greater than 35 for adults in the presence of weight-related comorbidities or greater than 40. And for children, it's a BMI greater than 1.2 times the 95th percentile with weight-related comorbidities or BMI greater than 1.4 times the 95th percentile. One thing to note about interventions for obesity is that the outcomes vary significantly. There's a significant amount of heterogeneity in response to a given intervention. You can see here for bariatric surgery, pharmacotherapy, and lifestyle modification therapy that some individuals lose quite a bit of weight, and yet other individuals even gain weight. Of course, there's less heterogeneity among patients getting bariatric surgery, but still some losing perhaps not very much weight at all and others quite a bit. And so the future of obesity therapy is really trying to identify who responds to which individual treatment. And finally, to close this session, I want to talk a little bit about the future of obesity and cystic fibrosis. We know that it's probable that with improved CF treatment, the prevalence of obesity in this population is also going to increase. And that as life expectancy increases in people with CF, that the health consequences of obesity will also be heightened. And finally, we definitely need research regarding appropriate treatment for obesity in this population. And thank you very much for your attention. I'm looking forward to answering questions during our live Q&A. Thank you.
Hello, I'm Rachel Grimes, a licensed clinical social worker at Cook Children's Medical Center in Fort Worth, Texas. I want to introduce you to Peaks the dragon, our hospital mascot. Peaks is going to help us remember what is most important in this presentation. Whenever you see Peaks, take note. Peaks will steer you towards the highlights. He may even show up when you least expect it. I'm going to share with you how I have been using motivational interviewing, or MI, to dance with our patients rather than wrestling against them. There are no relationships to disclose. Cystic fibrosis patients struggle with many areas of treatment adherence, including diet. Clinical interventions for increasing treatment compliance should be person-centered and appropriate for patient characteristics and health issues. Behavioral techniques such as token economies, contingency reinforcement, praise, and ignoring are practical ways to increase treatment adherence for younger children. For adolescents, adults, and parents of younger children, MI is highly effective in increasing self-efficacy and promoting treatment adherence. Pascal, mathematician, stated people are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the mind of others. When people want to make changes, they most often do so when it feels genuine and when it comes from themselves. Think back to any time in your life when someone attempted to tell you what to do. You didn't like it, did you? Did it make you want to jump right up and do exactly what they said to do? No. When others tell us what to do, we put on our brakes and find ourselves facing discord. Alan Zuckoff defines discord as ambivalence under pressure. Ambivalence about change is normal because change is difficult. When providers actively push for change by attempting to fix the problems, patients push back. MI focuses on working through ambivalence rather than resolving it, in an effort to help patients move towards positive change. When a patient is on a pathway towards positive change, the goal is to enhance and maintain that trajectory. Patients are the experts on their own lives. Providers oftentimes attempt to exert their professional expertise by convincing patients they have problems, arguing for the benefits of change, telling patients how to change, and warning them of the consequences of not changing. When this happens, discord is increased and the likelihood of change deteriorates. However, when providers work to create a therapeutic alliance by practicing MI techniques, they dance with discord and are better able to lead patients in a positive direction. MI has been described as a language. It's a way of talking that includes a set of skills used to have a conversation about change. When the patient voices the reason to change, it's called change talk. Rather than hearing us make the case for change, patients and families hear their own voices making the case, and it makes it easier for them to resolve their ambivalence about the change and then finally make that change. Essentially, MI is a way of arranging conversations so that people talk themselves into change based on their own values and interests. Throughout a conversation, a patient will demonstrate their ambivalence with change talk and sustain talk. We want to listen out for the change talk and focus the conversation towards that. The brain's natural tendency is to ponder changing, argue why they should, remember why they have not, and then stop thinking about it. This leaves the patient with a taste of the status quo in their mouth. We want the patient's last thought to be on change so that it lingers in their mind and the reasons for change start to weigh heavier than the reasons not to change. So how do we do that? The guiding philosophy of MI is referred to as the spirit of MI. This philosophy is described by Miller and Rolnick as a heart set and a mindset that encompass 4 domains: collaboration, acceptance, evocation, and compassion. Remember this acronym that stands for open-ended questions, affirmations, reflections, and summaries. Research shows that providers with the spirit of MI demonstrate advanced relationship building skills, which increase positive patient behavior and favorable clinical outcomes. When providers embrace the spirit of MI, they are able to apply the skills of MI, which are engaging, focusing, evoking. These act as a map for the interactions between the provider and the patient. The concept of acceptance is rooted in the work of American psychologist Carl Rogers. This does not mean you approve or acquiesce to the status quo. Showing the patient accurate empathy, affirming and valuing their worth, along with allowing autonomy, shows the patient they are accepted. When people experience themselves as unacceptable, they freeze and are unable to change. When they are accepted as who they are free to change. We all know that it takes a team to care for our patients. Without collaboration and partnership with our patients, we would dance ourselves right off the stage. Our job as healthcare providers is to create an alliance with our patients. Compassion is a deliberate commitment to pursue the welfare and best interests of another. I think we can all agree that we would not be here if we were not compassionate towards our patients and passionate about their well-being. The message we want to send with evocation is, you have what you need and together we will find it. We do this by focusing on strengths and resources rather than probing for deficits. Think of your most difficult patient, the one that you just do not know what to do with or for. See if you can identify one strength of that patient or family. Then I challenge you to focus on that strength, affirm that strength, and then build that strength on your next interaction with that patient. There goes Peaks again. Peaks told me before this presentation that if you learn one thing today, it's how to reflect what the patient says. Reflective statements make a guess about what the patient means. The function of a reflection is to deepen understanding and clarify meaning. Making reflections help the patients hear back the thoughts and feelings they are expressing, maybe in different words, and then help them ponder these thoughts. There are two types of reflections in MI. Simple reflections repeat back or simply rephrase what the patient said. For example, the patient says, "I'm just so tired of doing my treatments." The provider repeats that, making sure to keep the phrasing as a statement, not a question. "You're tired of doing your treatments." Sometimes the patient just wants to be heard and feel they are understood. Good reflections keep the patients talking, exploring, and considering. We'll talk more about complex reflections in a few minutes. First, we want to practice the simple reflections. Take a look at this phrase. "I want to lose weight, but I just love to eat, especially sugary treats. I can't stop myself when they're in the house. I know it's not good for me." What would a simple reflection be for this statement? If you said, "You want to lose weight," or "It's hard not to eat the sugary treats when they're in your house," you got it. Complex reflections take it one step further. Complex reflections add some meaning and emphasis to what the person has said. Complex reflections are strategically used to accelerate change. Take a look at the double-sided reflection. You love to eat sugary food, and losing weight is a priority for you. Remember how we talked about the last thing that is said is what we want our patients to linger on? This is what I mean by that. If I had said losing weight is a priority for you, but you love donuts and candy, the patient starts thinking about how much they do love sweets, and losing weight is thrown out the window. Another thing to notice about complex reflections is the word "and." In MI, we change our buts to ands. When someone uses the word "but" to connect two concepts, the first one is often disregarded. Although we do want to leave the idea of eating sweets behind, we have to ensure the patients know we heard them and we understand. And we also want them to focus on the change talk. You see how I did that? Complex reflections take practice. You don't need to be clever, just interested and curious. So let's practice. Here's the scenario. You are Dr. Hadid seeing 13-year-old Kayla and her dad. Kayla recently started taking Trikafta, and her BMI increased from the 68th percentile to the 87th percentile in the past 3 months. Using MI, you want to discuss how Kayla can improve her diet. You say, "There's one more thing I would like to talk about before our visit ends." What should you do next? Are you going to ask permission, or are you going to set the agenda? Well, it looks like Peaks wanted to help you on this one, so I'm going to click on asking permission. Yes, asking permission is not only respectful, but it also increases the patient's willingness to listen. Exploring prior knowledge and finding out the patient's interests allows us to fill in the gaps rather than repeat what the patient already knows. Listen carefully to what the patient says and then proceed to focusing. There are several goals to the focusing aspect of MI. We want to find out what information the patients want and need, match information to their strengths, elicit what information would be helpful, and provide advice that champion the patient's needs and autonomy. So what do we do next? You asked Kayla what her peers think about this because she mentioned her friends. We all know how important friends are to teens. However, in this situation, we led the patient towards sustained talk, not change talk. We needed to focus on what Kayla said about wanting to be healthy. In MI, it is always okay to step back, regroup, and refocus. And just like Peaks taught us, reflection is always a good option. Look at a couple of reflections Dr. Hadid could say to Kayla and her dad to focus the conversation towards change. Based on what they say in return, we'll determine if we keep on reflecting or if we can move forward towards setting the agenda. Agenda setting starts with a list of options and then moves forward towards an agreed upon focus. In this situation, we looked at the topics of importance already stated by the patient in their pre-visit planning form. We picked out the topics that relate to the goal of healthier eating habits and steered the agenda into a direction where positive change can be discussed. Pay attention and find out what is important to the family. Then use their answers to ask questions from these darn categories. Desire. How would you like for things to change? Ability. How confident are you that you can make this change? Reasons. What might be the 3 best reasons to change your eating habits? Need. How serious does this feel to you? Beware of asking the wrong questions. Why haven't you changed? Why do you have to eat junk food? Why aren't you trying harder? Why often puts people on the defense and then the dance moves in the wrong direction. Now we are ready for a plan. Remember, the patients are more apt to follow goals that they themselves create. So what should we do next? Should we ask Kayla and her dad what they think or begin to set the agenda ourselves? Peaks knows you already know the answer to this, so he hopped on over to ask her ideas. So I'm going to click on that. Dad suggests no sodas altogether. Kayla looks forlorn. You can lead the discussion to a compromise that will move the family towards positive change. Cutting out all soda will probably be difficult. What if we cut down to 1 per day instead of 2? And Kayla, you can decide when you want to drink your soda. Does that work for everybody? Wrap up your visit and ask if the team can follow up in a few weeks to see how it's going. One of the tools used in MI is the readiness ruler. The readiness ruler is a window into your patient perceptions on how they feel about change. It not only elicits change talk, it's an excellent, quick method that helps your patients feel like you are really listening. Try to get into the habit of using the readiness ruler in every visit. Peaks, where did he go? Peaks usually shies away from the slide because we all have the tendency to do the opposite of good listening skills. One way to increase your listening skills is to know what not to do in a conversation. It can be difficult, but I challenge you in your next conversation to really stop and listen and stay away from these 12 roadblocks outlined by Dr. Thomas Gordon, American clinical psychologist. I'm going to leave you with one last slide on what to do in a conversation when you're listening. One of my coworkers, Randy McKinney, says this: we all have a story. We all want to feel heard and cared about. When we are fully present for others and listen to understand their story, we build a bridge of kindness and compassion for the greater good of humanity. That serves us all.
Welcome to this session on the importance of exercise in achieving optimal health for people with cystic fibrosis. My name is John Lohman. I'm an associate professor and physical therapist in the UAB Adult Cystic Fibrosis Clinic. Feel free to contact me if you have any questions at my email address listed here. In terms of disclosures, some of the results that I will present today were funded by the Cystic Fibrosis Foundation. I have a current study funded by NIH looking at the effects of exercise in cystic fibrosis, and I am a consultant with rehabilitation and wellness specialists. Our objectives for today are to both review the evidence for both gaining weight as well as losing weight for people with cystic fibrosis, as well as to look at what a typical exercise prescription may look like and who you should consult with regarding exercise in this population. What are the common weight management issues in cystic fibrosis? Historically, the most common concern was not having enough weight. In this image, we have a approximately 15-year-old patient with cystic fibrosis who's had trouble gaining weight. He's had trouble being kind of as physically active as his peers due to shortness of breath. However, Ben Mudge decided to do something about that. He began a kind of a dedicated fitness routine, began eating a healthy diet, and by age 25, reported that he was in the best shape and health of his life. He had an FEV1 of 98%. Now he is 30 years old and runs his own fitness training company. He's a personal trainer for both individuals with and without cystic fibrosis. His CF training was always done remotely, even before it was cool to be virtual. However, much progress has been made in nutritional management of people with cystic fibrosis. And with the advent of the new modulators that seem to be improving GI function and nutritional absorption, we're seeing more and more people that are overweight and obese. These are results of a single center at the University of Minnesota that reported that only 6% of their patients were underweight, whereas 25% were overweight or obese. I have a feeling that many of our centers look quite similar these days. So what is the evidence that exercise can help patients with cystic fibrosis gain weight? We're going to review 4 particular studies here. The first study that we will look at is the shortest intervention of all. It included an in-hospital exercise training program. So basically 2 weeks of exercise while patients were in the hospital for an acute exacerbation of their cystic fibrosis. Patients were randomized into an aerobic exercise training group or a resistance exercise training group that exercised 5 days a week. There was also a control group that just received IV antibiotics and routine chest physical therapy. As you can see in the top table, at baseline, on admission, all of these 3 groups looked pretty similar. The bottom table are the results taken 30 days after discharge from the hospital. You can see that all 3 groups had gained weight, but the resistance training group had gained about 4 pounds more than either the aerobic or the control group. And they had, in particular, had gained fat-free mass, so they had put on more muscle. In addition, the resistance training group was stronger 1 month after discharge than they were at baseline. The aerobic training group basically didn't improve much at all, while the control group was actually weaker 1 month after hospitalization. Our next study was by Hebestreit's group out of Germany, looking primarily at the effect of supervised exercise training on FEV1, but they also looked at body composition. Their study involved a group that received either aerobic exercise training or resistance exercise training and kind of telehealth intervention for 6 months. You can see on the bottom graph that their pulmonary function actually increased during the 6-month period, and then it kind of dropped back down to baseline at 2 years, whereas the control groups gradually saw a decline in FEV1. In terms of body composition, though, the aerobic exercise training group kind of maintained their body mass at 2 years. The resistance training group actually weighed more 2 years later, and the control group had a decrease in BMI at 2 years. Our next study specifically looked at body composition, again with supervised exercise training in adults with CF. They found that body composition, although not mass, changed with exercise. So as we look at these results, the exercise group had an improved endurance after 8 weeks of exercise training. Their quadricep strength was stronger after 8 weeks. But there was no difference between the two groups in terms of body mass or BMI. And these were individuals that were pretty much normal weight. So 100 kind of mean body mass at the beginning was 122 pounds. BMI was 20. However, the exercise group had an significant increase in fat-free mass, meaning they had more muscle compared to the control group. Not all studies have shown such promising results. This particular study was a 3-month intervention. Both groups received kind of an educational session regarding exercise at baseline. And then the exercise group got exercise counseling over the phone every 2 weeks. They were encouraged to exercise 2 days a week for 20 minutes. So I will note that the dose of exercise in this particular study is much lower than in the previous 3 studies. What they found was basically no change in exercise capacity, BMI, body composition, but patients in the exercise group did report a higher level of physical activity. Now let's shift and look at the evidence that exercise can help patients with cystic fibrosis lose weight. I've found that in clinical practice, many patients, especially those that are underweight, are concerned about beginning an exercise program because they're worried it's going to cause them to lose weight. However, in the previous studies that we saw, almost all of the normal weight to underweight patients that begin an exercise program either maintained or had gained weight. As we begin doing exercise studies with patients that are overweight or obese, we may see different results. First, let's look at how our bodies spend energy. This is a pie graph looking at the total daily energy expenditure. The vast majority of our energy is spent with resting energy expenditure. So this is just kind of maintaining homeostasis. The light green in 10% is the thermic effect of food. So the energy our body spends digesting food. Depending on where we are in our stage of life, kind of a small portion is spent with growth. So building more muscle, more bone, growing tissues. But the portion of this pie graph that we have the most control over is the activity-related energy expenditure. So in the gray here, we have exercise energy expenditure. And in the gold, more of the non-exercise physical activity energy expenditure, what we call NEAT. So these are the things that our patients can do more of. So they can spend more time exercise, they can spend more time with habitual physical activity. But again, doing so, increasing your activity energy expenditure is no guarantee that you're going to lose weight because it could increase appetite. I didn't find any specific studies that looked at the effect of exercise in overweight and obese patients with cystic fibrosis. However, UAB was part of this particular study, and we had several patients in our intervention group that were overweight and obese that we will look at. Participants in the intervention group increased their activity-related energy expenditure by at least 3 hours per week above baseline. And this included some specific aerobic and resistance training exercises. They received exercise counseling kind of at visit 1B as well as at visit 2 and via telehealth interventions in the meantime. Here are the results of 3 of our overweight or obese participants that were in the intervention group. And you can see that they all 3 had a significant decrease in body mass at both the 3 and 6 month time points. Here are more specific results from the bottom individual. She was a 16-year-old that was having a pulmonary exacerbation at the 6 month time point. So she was subsequently hospitalized because her FEV was going down. However, at this point, her VO2 max had increased. She had developed more power. So her strength and her power was higher. She had lost 9 pounds and her BMI percentile had gone down substantially. So what does a typical exercise prescription look like, and to whom should you consult with and or refer if your patient is interested in exercise? And I will note that, like any drug, exercise is a medicine and needs to be dosed appropriately. So a typical prescription might look something like this, and which is really no different than it would be for a healthy individual. So an exercise prescription for someone with CF is pretty similar to a typical exercise prescription. So it includes both aerobic exercise and resistance. And so when we talk about exercise, we talk about the mode, the intensity, the frequency, and the duration. Um, Similar to what you would talk about with kind of a drug therapy. What's the route of administration? What's the dose of the medication? How frequently do you take it? How long are you going to take it? Um, so aerobic exercise is a continuous activity, large muscle groups, things that you do, walking, running, fast walking, hiking, cycling, swimming, uses big muscle groups. The intensity, especially especially once patients kind of get into the routine, needs to be kind of at the moderate to vigorous level. So 60 to 90% of the heart rate max. And the heart rate max is, a good estimate is 220 minus their age, kind of gives a heart rate max. Or their perceived exertion should kind of be a moderate to hard, or more, kind of perceived shortness of breath or perceived exertion, which needs to be done kind of at least 3 days a week, up to 5 days a week, probably 20 minutes per session, with kind of the goal of being up to 40 minutes per session. Resistance exercise, the mode for that can be various. So some patients use body weight, just using squats and push-ups and using their own body weight as the resistance. You can incorporate resistance bands, lifting free weights, machine weights, whatever the patient has available. The intensity here is kind of based on how heavy the weight is. So a typical prescription would be, to kind of gain strength and hypertrophy in some muscle mass, would be 2 to 3 sets of 6 to 12 reps. And the goal there is that at the end of that third set, you don't want to be able to do more than, maybe 12 reps. So if you can easily do 15 reps on that third set, then the resistance is probably too easy. You need to kind of increase the intensity a little bit, increase the weight that you're doing, the speed that you're doing it. And the higher intensity there, if you can only lift 6 to 8 repetitions on that third set, then that's more intense and is probably going to give you a little bit more gains in strength and hypertrophy or increase in muscle mass. This typically needs to be done at least 2 days a week to kind of 2 to 3 days a week to kind of gain strength, and about 1 day a week to maintain strength. If your patient is interested in beginning an exercise program, the first would be to consult with your local CF Care Center's physical therapist if you're fortunate enough to have one. If not, you can find a physical therapist in the community at the American Physical Therapy Association's Find a PT service. Some outpatient pulmonary rehab programs are accredited through the American Association of Cardiovascular and Pulmonary Rehab, and their program directory is listed here. There are also remote exercise resources. Beam has a platform that's specifically kind of devoted to cystic fibrosis. I'll mention it more on the next slide. CF Strength is the site run by Ben Mudge and that I mentioned earlier. The Pulmonary Performance Institute also offers kind of online pulmonary rehab for people with respiratory disorders. And I am a consultant with Rehabilitation and Wellness Specialists that offers telehealth services for patients as well. As I mentioned on the previous slide, Beam is an online platform specific for adults with cystic fibrosis. All of their instructors are either physical therapists or personal trainers with expertise related to CF, or they're people living with CF that have expertise in exercise and fitness. They offer a variety of live and on-demand exercise, educational, and well-being sessions. Their exercise classes include aerobic and strength training, high-intensity interval training, yoga, Pilates, dance, and mixed martial arts. They have classes to challenge both novices to exercise as well as those that just want to try something new. The CF Foundation is currently sponsoring free membership through the end of the year, so please encourage your patients to check out the link at the bottom of the slide to sign up. I have several patients from our center that use Beam, and they provided nothing but positive feedback. Thank you again for participating in this session. I hope you found it valuable. If you have any additional questions, please feel free to contact me at the email address listed below.
Hello. I'm Katie McDonald, clinical dietitian at Primary Children's Pediatric CF Center in Salt Lake City, Utah. It's my pleasure to present supporting healthy eating habits throughout the lifespan. Thank you for this opportunity. I have no disclosures related to this presentation. I wanted to present a brief history of dietary management of CF. Beginning in 1938, with the description of CF by Dorothy Anderson, low-fat diets were prescribed for infants and children with CF. This was a pragmatic effort to control the signs and symptoms of steatorrhea. Growth failure was recognized, but considered inevitable and relatively inconsequential in comparison to pulmonary health. In 1988, the Canadian group headed by Corey et al. Presented a document showing higher fat, higher calorie diets, or the CF legacy diet, that was accompanied by a liberalized enzyme management, and a median age of survival increased by 9 years over the control group in Boston at a CF center there. This diet, the legacy CF diet, became uniformly prescribed for all individuals with CF. By 2012, the approval of ivacaftor, the first drug to treat the underlying causes of CF in certain subgroups, showed weight gain as a secondary outcome. As additional CFTR modulators were approved for increasing numbers of individuals with CF, there have been mixed results regarding weight gain and growth. However, the legacy CF diet for all individuals with CF has really come into question. This legacy CF diet has been clinical dietary dogma for adults and children with CF in the past 30 years. It focuses on high fat, about 40% of the total caloric intake as fat, high calories, 110 to 200% of the usual caloric intake for age, a high salt intake, although in largely unspecified amounts, with less emphasis on dietary quality or individualized nutrition management. Many questions exist about nutrient profiles of this diet, including essential fatty acids, phytonutrients, fiber, and minerals. There are also questions about the implications of overweight in persons with CF and the high saturated fat diet for long-term health. Also, consumer preferences. Many persons with CF demand a healthy diet to complement their other efforts to attain best possible health. Current dietary habits in children with CF have been reported in multi-center studies of diet and nutrient analysis from Australia and the European Union. These studies have revealed high intakes of sugars, sweets, sweetened drinks, processed foods, and saturated fats. The high calorie, energy dense, nutrient poor foods, and this is in the diets for children, with accompanying low intakes of fish, legumes, fruit, vegetables, and nuts, the nutrient-dense foods. Current knowledge of nutrition intake in adults and children with CF shows an overdependence on saturated fat with relatively low polyunsaturated fat that may increase the risk of heart disease and inflammation. Dyslipidemia is prevalent, and the dietary impact is relatively unknown. More added dietary sugars with lower dietary fiber, poor healthy eating index scores than non-CF controls have been demonstrated, along with positive associations with added dietary fats or added dietary sugars, visceral adipose tissue, and elevated blood sugars. A systematic evidence review of the outcomes-related benefits of a higher fat diet for individuals with CF has shown that no benefit exists with a higher fat diet except in the context of achieving adequate caloric intake in a smaller volume of food. No evidence exists that CF confers any protection from consistently low quality food. Again, a systematic evidence review recommendation from the Academy of Nutrition and Dietetics CF Nutrition Guidelines. In terms of macronutrient distribution, it is suggested that persons with CF should consume macronutrients, carbohydrates, protein, and fat in the same percentage distribution as is recommended for the typical age-matched population. For overweight or obesity management, an age-appropriate diet that emphasizes foods associated with positive health incomes in the general population with higher nutrient density foods. These include vegetables, fruits, whole grain, seafood, eggs, beans, peas, nuts, seeds, dairy products, and meat and poultry. This is as tolerated and especially as preferred by the individual with CF, with energy needs adjusted to achieve or maintain normal growth in pediatrics or BMI status in adults. Food security is an important component of weight management and its impact on weight gain. Food security is defined as the limited or unreliable availability of safe and nutritious foods. Pre-pandemic, 1 in 9 Americans faced food insecurity at least some of the time. Food insecurity can be exacerbated by poor health or chronic health conditions due to higher medical expenses and possibly lost income with health limitations. A food insecurity obesity paradox exists. Food insecurity increases the risk of obesity. There are food deserts where no grocery stores are available, and food swamps where many people find only high-density fast food chains or convenience foods with lower quality, less expensive food, but higher in calories. As action items for all CF clinics, it is routinely recommended that patients with CF be screened with a 2-question food security vital sign. That CF clinics assist individuals with CF with eligibility information, enrollment, and maintenance of available resources. That is the copay programs, HealthWell, SNAP or food stamps, and WIC. Resources and more information are available through the Cystic Fibrosis Foundation Food Security Committee. Case studies. I have 2 case studies, and both of these case study families are seen by a CF Center dietitian on a routine basis at quarterly CF clinic visits. Both families determined their individual nutrition strategies and timing of the intervention that they decided to undertake. BMI percentiles for age are presented in these case studies. Our first is a 16-year-old female. She is heterozygous delta F508 and an E56X mutation. This young lady has had long-standing concerns for overweight. She was started in January 2020 on the triple combination drug and worried at that time about excessive weight gain. The BMI chart shows that she consistently has been about the 90th percentile for BMI through her teen years. The patient and her mother determined that they would increase their exercise, and both are running together, moderate portion sizes, and focus on healthy eating habits. In the 6 months following these interventions, you can see a decline in the BMI to about the 85th percentile. Both mother and daughter were pleased with this outcome. They reported the change they've instituted were sustainable, and the goal is weight maintenance for this young lady at this time. The second case study is also female. She is now an 8-year-old. She is homozygous delta F508. Her father described the family diet as, "We like hogs," and he proceeded to do a chant that they did at their home at meals about eating like hogs, complete with snorts and oinks. This patient started tezacaftor and ivacaftor at age 6 years. At that time, she was above the growth chart, the 97th percentile, for her BMI for age. The weight gain normalized for about a year after starting tezacaftor, ivacaftor, and then accelerated, as can be seen here. The family decided to reframe their description of the family diet. We eat like we want to be healthy. And they made healthy diet changes for the whole family, including a lower carb intake and controlled snacking. In the 6 months since initiating these changes, we have seen a reduction to the 96th percentile for BMI for this young lady. And the family is pleased with this outcome, and they plan to continue implementing continual shifts toward healthier family meals. In conclusion, optimal nutrition with appropriate body weight remains an integral component of CF treatment. Mutation-specific modulator therapy requires individualized nutrition care now more than ever. Opportunities exist for the inclusion of prospective nutrition-related data collection in large-scale, multi-center studies of modulator therapy. An oral diet based on the general public health recommendations, such as the Mediterranean diet, should serve as the basis for nutrition management in individuals with CF. Ongoing collaboration among the person with CF and family, the CF Center team, and the registered dietitian should inform individualized dietary management to attain both short and long-term nutrition goals for attaining optimal nutrition health. The goal really is a healthy diet for all individuals with CF. I have included my references here. And again, I thank you very much for this opportunity.
Hello, I'm Virginia Stallings. Very happy to be with you today. I'll be presenting on this session on the impact of CFTR modulators on weight management in CF. My disclosure is shown here. I have Vertex funding for an investigator-initiated research project in CF and nutrition. Here's a bit of an overview of what I'd like to cover today. At the beginning, we'll talk about where were we before 2011, before the modulator drugs came on the market. Then where are we today with the nutritional status? And then cover most of the data on the CFTR modulators with the ivacaftor experience. And we'll close with looking at the future and where do we anticipate going. So most of us have spent our careers in CF and nutrition really worried about malnutrition, growth failure, adults who were too thin for their height, and to promote healthy weight. During this time, our focus of care was increasing calories, much more than a typical healthy person would eat, optimizing fat and enzymes to enhance fat absorption. We've also spent most of our time monitoring nutritional status, just looking at growth. And as we started to use BMI as a way to screen, that became a big part of our care story. I think we would all agree that things changed a lot once we started to understand the CFTR mutations in the context of specific small molecule drugs to treat it. And the breakthrough came with the class 3 drugs, with those people with what we call gating mutations, and the introduction of ivacaftor. I think a couple of other things need to be brought up in the context of the discussion. One, as a pediatrician, I'm very gratified now to see that there are more adults with CF than children. And this really does speak to the improvements in care across all the spectrums of care, but certainly including nutrition. So we have to think about our adults. Now, the comments about where are we today, I just wanted to show a couple of slides from the patient registry that I think illustrate this point very well. Here you see the data over the past years for infants under 24 months. And now with newborn screening, fortunately, most of the patients are diagnosed here. And if you look at the bottom line, the red line, that shows you where we are with length status. And even today, over this time period, we're not doing very well. We're at a median of 30% for length. Weight's been doing a little bit better, but we're still not up to the 50th percentile. But with that, you see, because BMI is derived from those two variables, you see that BMI looks good. It's above the 50th percentile. But I always want to call us back to, as the clinicians and the people dealing with the patient care, that we really have to follow the weight and height specifically. Now, looking at the same type of data for patients who are 2 to 19 years of age, again, using the most recent data, you see the same kind of trend, that our lagging indicator is height. And even in this age group, we continue to have growth faltering in the height or a bit of short stature compared to what we think will be their genetic potential. As we moved into more attention with nutrition care and adults, people over 20, here's showing the similar graph from both men and women. And as you recall, the general guideline is to have all of our women with CF have a BMI at 20 or 22 or above, and for men, 23. And we have made progress, certainly over the last 2 decades. So now shifting to the core part of what we wanted to talk about is what are the modulators doing to nutritional status? And ivacaftor certainly is the drug that we know the most about. It's been around the longest. It was the first to come into clinical care, and it was the most effective drug we've had in all of these classes. So as you recall, class 3 mutations, gating mutations, and at the beginning, with G551D, the response to the medicine was really quite remarkable. Now there are 38 different mutations approved for this therapy, and that represents up to about 15% of people with CF. As you expect in clinical trials, the early data for approval was in adults, and then for teenagers, and now it's approved down to 6 months of age. When you look back across the data through all these studies, you do see a consistent weight gain across all ages and across all studies in ivacaftor for class 3 mutations. Usually you see an increased height velocity when you look at percentiles or Z-score in children. And as the work went on, we and others showed that the mechanisms for this are really related to decreases in resting energy expenditure, decreases in gut inflammation, and an overall net increase in dietary fat absorption. Over the last few years, interesting work has been coming out specifically related to the GI tract and some of the symptoms there, showing that there's an improvement in gut pH, which does tell us that there is an increased secretion of bicarbonate, improved symptoms of gastric reflux, and data now coming out showing that the bile acid abnormalities of CF are also improving. And each of these would be elements that would increase the likelihood of improved nutritional status. So what we have is now in this setting, increased absorption, better absorption of calories and better fat absorption, and thus a better energy balance. And I also wanted to mention, because these drugs are all fat soluble, we're also having a small increase, the data suggests, from people eating more fat because they need to take it with their drugs twice a day. Just to use this example from one of the early studies, with ivacaftor, this is the pattern that we're really seeing, where over the first 16 to 24 weeks, you see a fairly rapid increase in weight. This chart shows the change in weight in kilograms, and then that appears to be sustained over the rest of the year. And if you look at the whisker bars, the standard deviation, you can see, however, that varies greatly. Some patients are continuing to gain weight, and others are probably staying the same. And those on placebo really had very stable weight over that year. Now, when we move on to the other drugs that have been approved for care in CF, the story's a little bit different. Nothing else has had that really big magnitude of effect that ivacaftor did. So as you know, the ivacaftor-luminacaftor combination came on. It was focused on class 2 mutations. And when you look at the data in adults, you see that there were some changes in BMI, but it was mixed. Again, so a more modest increase in weight. Then the ivacaftor-tezacaftor, which was designed for people with the 508 homozygous mutation, in these data sets, you did see a change in BMI in children, but it was often a trend and not statistically significant. So again, not such a big change. And now we're just beginning to really understand the triple therapy, the trikaftor. And this is the other drug that's considered more highly effective in the way that ivacaftor was. And in the data that's come out in clinical trials and in early clinical use, we are seeing increases in BMI and weight. Again, not at the magnitude that we saw in those first ivacaftor studies. So in thinking about this presentation today and doing some reading, there were a couple of other things that I came across that I wanted to really emphasize. One, that we really are in a setting where we have to remember that there's significant variability in response to therapy. And we saw this even with ivacaftor with the most perfect mutation match. And it is likely that there are a lot of other genetic variants that are not CFTR related that are having an impact, whether it's an impact on the lung response or the gut response. So this will always be fairly individual. In that same sense, we have really good documentation of the changes in lung function and the variability, because that's usually the primary outcome. But it's likely we're experiencing some of that same, this patient does better than that, in response in the gut, pancreas, and the liver. Another interesting thing is, now that we have more data, that they really have uncovered sex differences in the response to these new drugs. And particularly in the sweat chloride response, which can be easily measured, and even in the rate of pulmonary exacerbation. And in these two outcomes, female patients are doing better. However, they're gaining less weight than males. So there really are still sex differences playing out in CF. And just to mention something we've all known and regret, that females with CF still have a lower life expectancy. At this point, 2.7 years difference between females and males. And I think one of the things that we hope with the new therapy and new approaches, that we would be able to see a decrease in this. So when you think about the future, I think we really should be focusing on the idea that the highly effective drugs are going to be the ones that are going to be used for treatment in as many patients for whom it's appropriate. And that really will be the ivacaftor and the trikaftor. The non-pulmonary data that we need, and we need to keep watching for and insisting for in studies, is for, if you will, our nutrition-related organs, so the pancreas, liver, and gut. We'll continue to follow what's changing with both systemic and gut inflammation, because we know that's part of the story with improving nutritional status, and continue to follow what happens with dietary fat absorption. We also expect that there could be changes in food intake, total calories, and food pattern, for example, the amount of fat. But we're going to be going back and forth, because we have the infrastructure that we've always told people to eat more food and eat more fat. And now we may not have the necessity to push those many calories in every single patient. We have very little data at this point on changes in physical activity. We have hope that taking the new medicines will make people with CF feel even better and more physically active. And that'll be another variable in the energy balance equation. So in sum, the issue really is going to be, how do we look forward to individualized care for each patient? Where do they start from? What kind of response do they have to the medicine? How do we anticipate keeping them in optimal nutritional status? So here, I think we are going from a place where that we used to measure, almost always worried about growth failure and underweight status for adults. And going forward, we may also need to be thinking about people who are gaining too much weight. And here I have a slide of a DEXA scan, happens to be of somebody who is overweight, but also to remind us we need to begin to shift from just following weight and height to also beginning to thinking about optimizing body composition. Here are a list of other recommended reading that I found very helpful, and I encourage you to take a look at those. Thank you.